Hello everyone, welcome to this video series on EKG that is designed specifically for the doctors in training. Now I've been doing this EKG series with family medicine resident, internal medicine resident and medical students for last 2 years. And one thing I can assure you and say with full confidence is that after going through all the video lectures, you will not only start reading EKG with more confidence and clarity, but you'll actually start to understand what is going on inside the heart and what is the underlying mechanism that makes EKG look like the way it looks. All right? So it doesn't matter how much have you disliked EKGs in the past, I promise you this video will surely help you to read EKG in a much better way, and you will see a noticeable difference in the way you interpret EKGs. So without any delay, let's get started. Right. So I know some of you are resident have good hold on the basics, but we'll still go over everything like starting from the scratch and then build over the more complex concepts. So in the first slide, as you can see, these are the width and height of the EKG blocks. If you see a block here, one small block is 1 millimeter in width and 1 millimeter in height. Now the thing that you need to understand is the height correlates with the amplitude and the width correlates with the timing. So 1 millimeter is equal to 40 milliseconds, as you can see here. And the height of 1 millimeter equals to 0.1 millivolt. These are the two numbers that you absolutely need to remember to avoid any confusion when you are reading EKGs. Now another thing that happens recurrently is you keep forgetting these numbers. So for timing, I would recommend, at least for the initial period, to just remember the timing only in milliseconds. That will make it easy. So one small box is 40 milliseconds and 5 small box, which makes one big box, is 200 milliseconds. And this is for a standard EKG speed of 25 millimeter per second. All right, this is the basic formula to understand the rate on the EKG and how you can calculate easily without any delay. So to calculate rate, if your rhythm is regular, if the RR intervals are coming on time, divide 300 by number of big blocks that you see on the EKG. So here you see the number of big blocks between RR interval are 5. Divide 300 by 5. That will give you a heart rate of 60 beats per minute. Now why are we dividing it by 300 from 300? Because 5 big boxes makes 1 second. So 300 big boxes is equal to 60 seconds, which is 1 minute. And when you divide the number of RR intervals by that, you will get the heart rate per minute. This is the formula you can use for when the rhythm is regular and the RR interval are coming on time. But what if it's irregular, like something like AFib? In that case, you can use another formula where you can calculate all the number of QRS complexes in the EKG in one strip and then multiply it by 6. Why multiply it by 6? Because every EKG is a 10-second snapshot. And when you multiply by 6, you can get the rate in 60 seconds. So look at here. For example, this one has 1, 2, 3, 4, 5, 6 QRS complex. So multiply 6 by 6, which will give you a heart rate of 36. This is just an arbitrary example, but just for your understanding. All right, now comes the most important concept of EKGs, and that is to understand the vector. And doesn't matter if you have never understood this concept before, we'll make it simple. And once you understand vectors, it will start making sense why EKG looks certain way. And for that, let me just open a blank page. All right, so understand why certain waves are upright and certain waves are going downwards, why certain waves are biphasic. And for that, you need to understand how the leads record different depolarization and repolarization. So let's take an example. Let's say there is a lead V1. Now if the depolarization is coming towards lead V1, it will give you a positive deflection. All right. If it is going away from V1, it will give you a negative deflection. Same thing applies to all the leads. And if the depolarization is moving perpendicular to the lead, then it will give you a biphasic wave. So let's say this is V1 and the wave is going in this direction. So from here till here, the lead will assume that the depolarization is coming towards it. So it will give you a positive deflection. And when it is going away from the lead, from this point to the rest of the point, then it will give you a negative deflection. That's why you see biphasic wave on some of the leads. And when it is biphasic, you need to understand that the wave is going perpendicular to the lead. So let's try to understand that on the vector diagram that we had. Let me actually show you here. So this is how the heart is placed in the middle of all the limb leads, and imagine these limb leads as cameras. So AVL is looking at heart from this direction, lead 1 is looking at heart from this direction, and so on. So whenever, let's say, a wave is going towards V1, then V1 will have a positive deflection. Let's say a wave is going to, let me just go through this again, sorry. Whenever the wave is going towards lead 2, the lead 2 will have positive deflection. And because majority of the time the vectors are going away from AVR in this direction, I'll draw the trajectory in a while, this AVR will always have a negative deflection. Let's try to understand the normal electrical route of the heart. So here is your SA node, roughly speaking. It is going towards the AV node. Let me change the color. From AV node, it will come down to bundle of His. From bundle of His, it will divide into left bundle and the right bundle. And then it will eventually go into Purkinje fibers. Alright, this is the normal route of the electrical activity in the heart. Now if you see, basically vector is a mean of the electrical current in the heart. So where is the direction of overall depolarization or electrical current in the heart is what the vector is. So if you look at SA node to AV node, the atrial depolarization, the direction of it is from SA node towards the AV node. So if you see the direction towards which the electrical activity is going in the atrium is in this direction, roughly speaking. So the EKG leads, all the leads will look at it in that way. So if you look at this direction, lead 1 will assume that it is coming towards it. So you will have a positive deflection. Even to AVL, it will seem like it's coming towards it. So it might have a positive deflection. Lead 2 will have a positive P wave as well. Same with lead AVF, positive P wave. But lead 3, if you see, it is usually perpendicular to this wave. So for lead 3, many times you see a biphasic P wave. And that's completely normal for an EKG. Same thing for AVR, because the direction of, let me just clean all this. The direction of the depolarization is from SA node to AV node, and it's away from AVR. AVR will have a negative P wave all the time. So whatever these leads are showing, AVR will show exactly opposite of that majority of the times, unless there is different direction of the vector. Now let's try to understand the vector for the ventricles. Now when it's moving from AV node towards the left and right, one thing we need to understand is that left ventricle forms the majority of the chunk of the ventricle. The myocardium is thick and majority of the electrical current flows towards the left ventricle. So if you see the direction of the vector, it is mostly directed towards the left ventricle. Alright, and this is something you need to understand why the QRS looks the way it looks. So let's go back to the different slide here. So let's try to understand on this diagram. See, let's assume that the normal direction of the vector is somewhat in this direction for the ventricles. So what happens is, majority of the times this ventricle vector is between lead 1 and lead AVF. So it doesn't matter what the direction is, both lead 1, as far as it is within the range of lead 1 and AVF, the QRS complex will be perceived as coming towards the lead. So if it is going in this direction, lead 1 will think it is coming towards it, so there will be a positive deflection. And same thing with lead AVF, there will be a positive deflection as well. Up to -30 till +90 is normal. Now there are certain numbers on the screen that you absolutely need to remember. Those are -30, 0 degrees, 60, 90 degree, 120 and -150. These are the position from where all the limb leads are looking at the heart. Now let's try to understand what the left axis and right axis deviation looks like. So understand, let's say if the vector is going towards this direction. So here if you see, lead 1 will still see this vector as coming towards it. But if you look at AVF, it is going away from it. So in that case, lead 1 will have a positive deflection, but AVF will have a negative deflection. And this portion is called left axis deviation. All right. Same thing, same concept for the right axis deviation. Assume, let me clean it up actually. Let's say the vector is going in this direction. So in that case, AVF will still perceive it as coming towards it. Anything between 0 to 180 degree, AVF will perceive it as coming towards it. Anything on the other direction, it will see it as something going away from it. So here, it is coming towards AVF. So AVF will still have a positive deflection. But if you look at lead 1 is looking at from the other side, and the depolarization is going away from the lead 1. So lead 1 will have a negative deflection. That's how you determine if the axis is right axis deviation or left axis deviation. There is something called extreme axis deviation, or it's called northwest axis deviation, where the axis is going in this direction and you will see a negative deflection in both lead 1 and AVF. I hope it's clear, and once we understand this vector, we can easily understand what the more complex concept looks like. All right, now this is a perfect diagram to understand how all the leads are looking at the heart from what directions. So if you see lead AVL and lead 1, they are looking at heart from this direction. All right, AVR is looking at the right side of the heart, and lead 2, 3 and AVF, they are looking at heart from the bottom. So understand one thing here. Lead 1 and AVL, they are looking at the lateral border of the heart. So that's why they are called lateral leads. Lead 2, 3 AVF, they are looking at the inferior border of the heart. That's why they are called inferior leads. In the same way, the same concept applies to the precordial lead. If you look at lead V1 and V2, they are looking at the right side of the heart and the septum of the heart. That's why many times they are referred to as septal leads, or more commonly they are called as enteroseptal leads when they are combined with lead V3 and V4. So look at V3 and V4, they are looking at the anterior surface of the heart. That's why V3 and V4 are called anterior leads. And V5 and V6, just like 1 and AVL, they are looking at the lateral border. So again, they are called lateral leads. We'll see this in a moment. Look at this. Lead V1 to V4, they are all called enteroseptal leads. V5, V6 are called lateral leads, just like 1 and AVL. And 2, 3 AVF are called inferior leads, and I hope it makes sense. So whenever you see ST elevation in one of the leads, you actually know what kind of infarct the patient is having, and based on that you can predict what artery might have been blocked. So if you have any blockage in left circumflex or the diagonal branch of LAD, it will give you lateral infarct. If you have any blockage in RCA or right coronary artery or left circumflex, it will give you inferior lead infarct. And if there is any blockage in LAD, it will obviously give you enteroseptal infarct. All right, let's try to understand this again. See, whenever there is electrical activity movement in any of this direction, either left to right or up to down, your limb leads will be able to record it. Whenever there is movement in anterior posterior direction, your precordial leads can record it. So the limb lead looks at the EKG in the frontal plane, and the precordial lead look at the horizontal plane. All right, this is what we discuss about the axis of on the EKG. So if it is between 0 to 90 degree or up to minus 30 is normal, then it will have positive deflection in lead 1 and AVF, and that is normal. If it is positive in lead 1, negative in lead AVF, that is left axis deviation. If it is positive in AVF and negative in lead 1, that is right axis deviation. And if it's negative in both, then there is extreme axis deviation. Now let's try to understand the nomenclature of all the segments, intervals and waves itself. Now being a resident, it might seem like you know what the wave nomenclature is, but we'll go over it again just so that you have clarity in depth. So we have P wave, which represents atrial depolarization, QRS, which shows the ventricular depolarization, this atrial depolarization, and T wave, which represents ventricular repolarization. Now ventricular repolarization is a slow process, so that's why the width of QRS is always more than the width of T wave is almost always more than the width of QRS complex. PR segment shows the hold of electrical current or the delay in the AV node, and ST segment is the difference between ventricular depolarization and ventricular repolarization, the timing between that. All right, Now, one thing that confuses all the residents is the interval. And why is it so? Because if you look at the PR interval, it starts from beginning of P wave, but it does not include R wave. It ends right before the QRS, that is PR interval. But in the other way, if you look at the QT interval, it starts at the beginning of Q and includes the T wave. So this is what makes it confusing, and that's why many a times people have hard time remembering this. So remember, PR interval does not include the R wave, but QT interval includes both Q and T wave. And then you have the segments, the PR segment, ST segment. All right. Second thing you need to understand here is the nomenclature of QRS wave. So any first downward deflection on the EKG in the QRS segment is termed as Q wave. Any first upward deflection is R wave. The downward deflection after the upward deflection is always S wave, regardless of there is a Q wave or not. And if you have a second R wave, for example, something like this is called R wave, and the second one is called R prime wave. If you have a wave which is something like this, then the first upward deflection is R and the first downward deflection is S wave. So this is called RS complex. And the last one, if you have just one downward deflection, we call this QS complex. This is Q, this is considered S. So this is called a QS complex. So whenever you hear this term RS or QS, you need to understand what exactly that means. Alright, some important numbers to remember. Even if you forget all other numbers, try to remember these three numbers and you will do really well with the EKGs. First one is PR interval. It should be less than 5 small boxes or less than 200 milliseconds. If it is more than 5 small boxes, it represents either first degree heart block or Mobitz type 1. Second number to remember is QRS duration. If it's more than 120 millisecond or more than 3 small boxes, which we call wide QRS, it has two different possibilities. Either there is a left or right bundle branch block, or the arrhythmia is coming from ventricle. So arrhythmias of ventricular origin will have wide QRS, and also left and right bundle branch block will have wide QRS. So bundle branch block or arrhythmias of ventricular origin. So the QTC interval is less than 440 milliseconds in male and less than 460 milliseconds in female. Alright, there is a quick, cheap and dirty way of knowing if the QTC is prolonged or not, which we'll see in upcoming slides. Now we come to the most important slide of this video, and that is the format to read the EKGs. This is a standard format to read the EKGs: rate, rhythm and axis, and most of the people follow this with slight variation. And I promise you, if you go through this format step by step, even the toughest of the EKG will give you answer. Even now at the end of my training, whenever I am stuck with something, if the EKG is complicated, I follow these steps and I reach the answer right away. So make sure you develop a habit of going through this format and do not jump directly to determine what the rhythm is. So the format to read EKGs is rate, then comes rhythm. The first and most important question, is it sinus rhythm or not? Which means, is there P wave or not? If you find the P wave, it will give you 80% of the answer for the EKG. Then you determine AV conduction, or what we call PR interval, IV conduction or IV conduction or QRS duration, relation between P and QRS. Then you see different kind of segment: PR segment, ST segment, either there is elevation of ST segment, depression, stuff like that. And then you see QT interval, if it's prolonged or not. And the last step is to go to the axis. If you see left axis deviation, right axis deviation, it can give you hints for left anterior fascicular block, left ventricular hypertrophy, right ventricular hypertrophy, and stuff like that. All right, some important rules for reading the EKG. The first and foremost rule is check all the 12 leads. A lot of time I sit one-on-one with the residents and they say, oh, I don't see a P wave, looks like AFib. I ask them to check all the leads, and when they check all 12 leads, they find a P wave. So whenever you want to see a P wave, the best leads are lead 2 and V1, where you have the best chance of seeing a good P wave. But make sure you check all the leads. That's very important. Second is spend enough time with the EKGs. I recommend, as a new resident, spend at least 3 minutes with the EKG, and you will see how much more information can you extract. One of my mentors told me that if you want to appreciate an art, you need to look at the art for at least 10 minutes and then you can make a comment. Reading EKG is no less than an art, and if you spend 3 minutes, the EKG will start talking to you. If you spend 5 minutes with the EKG, it will start screaming at you. And I can tell you something, no one will diagnose you with schizophrenia because of that. Alright, next 2 points are always compare with the old EKGs and always clinically correlate. Let me give you an example for that one. We had a patient in ED that came because of ST elevations. ED called me, I went to see the patient. I looked at previous EKGs and he had ST elevation for last 15 years. It was completely unchanged. Second thing, I spoke with the patient. He was completely asymptomatic. So if there is ST elevation, you expect some form of angina or angina equivalent symptoms. Patient has chest pain, abdominal pain, jaw pain, neck pain, something. This patient was completely asymptomatic. I spoke with the patient. He said that, doc, I have been having this kind of EKG finding for last 15 years and I have been sent to ED multiple times. I changed my PCP today and I told them it is normal finding, but they still insist that I come to ER. So make sure you compare with the old EKG and you do a clinical correlation that will give you answer to a lot of the questions that you might have. Now, before we jump into different arrhythmias, let's try to understand what a normal EKG looks like, and then we can go and explore more complex concept. So if you look at normal EKG, the P wave is upright in lead 2. If you see, QRS is mostly positive in all the limb leads except in the AVR where it is expected to be negative, as we understood before. AVL sometimes can have negative deflection or biphasic QRS based on the direction of the QRS. If QRS is, let's say, pointing towards AVF, if QRS going towards AVF and lead AVL is looking from here, so it perceives it as a depolarization going away from it, which causes a negative QRS, which is a normal finding. Next important thing to remember is in lead 3 and lead V1, you might see something called biphasic P wave. Now comes another important concept, and that is to understand the R wave progression in precordial leads. If you see, the R wave is small in V1, and as you keep going towards V3 and V4, the R wave keeps rising. This progression of R wave, the rising of R wave amplitude, is called normal R wave progression. If you do not see this kind of elevation in the amplitude of R wave as you progress from V1 to V5, that's called loss of R wave progression, and you keep hearing this term again and again, and we'll discuss in the chapters on ischemia and infarct what that exactly means. Let's try to understand why there is a normal progression of the R wave, and that will help you understand. Many times you hear that the leads are misplaced and all. It's very easy to understand. So look at this EKG. The direction of QRS is somewhat in this direction, right? So if you see the QRS depolarization, I mean ventricular depolarization, it is pointing towards mostly V4 or V5. That means the R wave will be most positive in V4 or V5. If you look from V1, initially there is a small wave that V1 perceives as coming towards it, and then there is a wave that is going away from it. Look at here. So V1 till this point it will have a positive deflection, and from this point onward it will have a big negative deflection, which is a normal finding for precordial leads. So once you understand what a normal EKG looks like, it will be easy for you to understand what abnormal EKGs look like. Second thing that or actually the last point that I want to discuss is how to quickly determine if the QT interval is normal or not. So if you come halfway between the RR interval, let's say halfway is somewhere here, if the T wave is crossing that halfway, then in all likelihood the QTC would be prolonged. If it is not touching that halfway, then the likelihood of a normal QTC is high. So that was all about the basics of the EKG, and based on the knowledge here, we'll try to build up and understand more complex concept in the upcoming videos. Now, to finish the lecture, I'll read a quote from Benjamin Franklin. It says, "Tell me and I forget, teach me and I may remember, involve me and I learn." So the most important thing to remember is to keep practicing what we have learned in your real life day-to-day practice. Only then you will be really good at reading EKGs. I hope you enjoyed this lecture, and if you did, I'll see you in the next lecture. Thank you for your time.